I'm grateful to the Maharashtra Medical Council for initiating this program on continuing professional development program. Building telemedicine into clinical practice is a vital part in any doctor's clinical practice. Over the next 35-40 minutes, I intend to show to you how this needs to be done. What is telemedicine? Telemedicine is the delivery of healthcare services where distance is a critical factor. We need to understand the process of telemedicine. Personally, I think the words patient and doctor should today be replaced with beneficiary and healthcare provider, because even nurses, nursing assistants, physician assistants may be involved in delivering healthcare. A good telemedicine program should necessarily concentrate on hardware, software, connectivity. We need to acquire laboratory reports, images. Obviously, we need to store them, retrieve them, display them, digitally manipulate them. Telemedicine is changing at breakneck speed, and therefore it is essential that all the people who are using telemedicine have formally trained in this. We also need to customize a telemedicine program to suit specific needs. No telemedicine program will succeed if it is not cost-effective, compliant with regulations. We need to be self-sustaining, which means revenue generating. Someone has to pick up the bill somewhere. And most important, we need to be future ready. What are the advantages of telemedicine? Well, it makes the right expertise available anywhere, anytime to anyone. Early provision of appropriate treatment, improved access and quality of care, and in certain situations, one can even use it for emergency consultation. Of course, it saves cost to the patient, the provider, and the entire healthcare ecosystem. Most important, it establishes continuity of care. Public awareness is very essential to ensure the growth and deployment of telemedicine. Continuing medical education, disease surveillance and program tracking, disaster management, these are some of the telemedicine applications. Let's spend a minute in trying to understand what are the benefits of telemedicine. The patient can get a healthcare consultation from his work spot. He does not have to travel. Obviously, the associated cost will considerably come down. Government will realize that there will be reduced spending on infrastructure and workforce, relatively easier access to specialists and super specialists. The quality of healthcare will certainly improve because patient engagement is increased, and more important, the continuum of care is established with much easier follow-up. Let's look at the healthcare workforce. There will be a new creation of a new cadre of healthcare personnel, telehealth facilitators. We often forget that there is considerable effort involved in seeing a doctor, right from making an appointment, traveling all the way to the doctor's clinic or hospital, waiting in line with other patients, seeing the doctor again with the results of investigations, showing the reports, getting a prescription refilled, follow-up visit, and so on and so forth. Today, with modern ICT, information and communication technology, geography has become history. Distance has become meaningless. As a continuous communication between the doctor and the employee, we can see each other via a video system and converse about the treatment being followed. The first step is to assess. This topic is entirely about deploying telemedicine in one's clinical practice. So if I were to start telemedicine consultations, what would I do? First of all, I would assess the situation. One size does not fit all. We need to understand that any telemedicine system has to be customized to suit your specific needs, the clientele with whom you are dealing, where you are physically located, where the patient is physically located, the status of information and communication technology, and so on and so forth. So the first thing, perform a situational assessment of your private practice. Analyze the average number of footfalls, assess existing competition, and evaluate areas needing a focused approach. After assessing, we need to implement. How does one implement? First of all, start with patients who are interested in availing a telemedicine service. In other words, who are not totally digitally illiterate. The success of your initial remote healthcare technology enabled should motivate other patients using success stories. Adaptation is the name of the game. Understand the patient requirements, regularly evaluate, re-evaluate, unlearn, relearn, change your telemedicine practice so that the patient goes back with a wow, that was a great consultation. So you need to adapt. One has to grow, be open-minded to include new ideas. Technology is working at is spreading so fast, growing at breakneck speed. You need to understand that this talk may actually become obsolete within a year from now because of the tremendous advances of technology. So please remember that this is a dynamic situation and not a static situation. I do not intend to make you concerned about patient consent. The telemedicine practice guidelines have unequivocally and clearly mentioned that we have what is called an implied consent. So when the patient takes the initiative and wants to consult a doctor through a telephone or video conferencing, the consent is already implied. However, if it's a formal telemedicine system, we need a digital consent form. Patient privacy. Unlike a face-to-face consultation where the patient normally encounters only the doctor, here there could be other people involved, a technologist, and of course the communications department also. So we need to ensure that patient privacy is there. Whenever I give a teleconsultation, I ensure that none of my staff or assistants who normally would help me are there when the actual consultation is taking place. The world is changing rapidly, and I think a great sign of advancement in India is the government authorization of insurance providers to reimburse teleconsultations. And please understand that medico-legal cases, the same rule applies in a teleconsult as in a face-to-face consultation. There cannot be a successful teleconsultation system unless the doctor gets adequately or at least reasonably reimbursed. And today, with opening of payment gateways, which I will elaborate later, reimbursement from a distance, from hundreds of thousands of miles away, is relatively simple. A good telemedicine system must have a comprehensive electronic medical record. Though it may be difficult to initially implement with, as the months and years go by, all of us will find we would all be wondering how we were managing scribbling notes. Awareness, familiarity, service uptake is all very important. Telemedicine practice is data-driven. Regularly evaluate data outcomes to gain insights into the performance of telemedicine. Patient satisfaction includes the patient experience with the telemedicine service. Number of times a patient comes back, what we call the loyalty loop, active evaluation, and finally, the conversion rate of patients. For all this, you need to maintain data and analyze the data. All of us are clinicians. We are not primarily technologists, computer scientists. And therefore, you need to remember that telemedicine, telehealth, use of technology is only a means to achieve an end. I belong to the BC era. I'm not talking of before Corona. I'm talking of before computers. I was the last neurosurgeon in this country to be trained in neurosurgery even before the CT scan came. And therefore, I would like to reiterate with all the force at my command that clinical wisdom and judgment still plays the most important part. And what do I mean by clinical wisdom? We should be contextual. What is to be done at that time, at that place, for that patient, for you, from where you are, taking the socio-economic picture and specific requirements of the patient and family at that time. Contextual is the single most important word. This and this alone will decide on the use of telemedicine. It's interesting to find out who initiated the teleconsultation, because an in-person visit was not possible, or was it because they wanted to use technology, etc. So try to find out. And finally, never ever get overawed by rules and regulations. The courts and the National Consumer Protection Forum have repeatedly said that it is clinical judgment overrules even existing rules and regulations, so long as you exercise a particular technology for the benefit of the patient. The more the technology is being used, more will tender, loving care be required. As a clinician, do your best, act in good faith. Always have only the patient's interest first and foremost. When I started telemedicine almost 20 years ago, when the technology was nowhere near what it was, in dozens of cases, I have stopped the teleconsultation because I was just not happy with the quality of the audio, the video. I felt I could be making a mistake, an error of judgment, and therefore I explained to the patient, I'm sorry, I'm not able to give an opinion. Today, things are certainly different. However, you need to understand that a teleconsultation does not always replace a physical exam. I had mentioned earlier about the importance of the word contextual. For example, being a doctor trained in the BC era, I would still like to do a rectal examination to find out about prostatic enlargement. However, my student may be very comfortable with a 3D pelvic ultrasound with Doppler, and he may think a PR, a per rectum examination, is unnecessary. He is not wrong, neither am I wrong. So you and you alone can decide whether to continue with the teleconsultation or not. This is very, very important. You need to understand that the standard which the courts expect in a consultation is exactly the same as that in a face-to-face consultation. Ultimately, it is the individual behind the machine that counts. Professional judgment alone matters. Now, you need to have a workflow, streamlining of all processes, appointment scheduling, seamless planning, patient experience, staff management, workspace, etc. I'm not going into the details for time because of time constraints, but this video will be available online, and those of you who are interested, please replay this. Now, let's spend a minute on the illustration of telemedicine practice workflow. Again, I'm not going into the details of registration. It is common sense that we need ideally to give a patient a unique ID. With the ensuing availability of a UHID, a universal health indicator like a 12-digit Aadhaar number, I dream of the day when everyone of 1.4 billion Indians will have a unique UHID, and this UHID will be used in every healthcare transaction between the patient and the doctor, irrespective of whether it is in a primary health center at the All India Institute of Medical Science or in any corporate hospital. Patient details like name, phone number, address, occupation, MMC, non-MMC, all this should be registered, appointment details, and of course, also you need to record somewhere the payment of the consultation fee, choosing the payment gateway, documenting the presence of insurance for reimbursement, etc. E-pharmacy, e-consultation is a huge subject by itself. The telemedicine practice guidelines, which is freely available on the internet, very clearly tell you how to provide e-prescription, and I will also be mentioning about this later. Now I assume that you have understood whatever I have said so far, and you are ready to start a telemedicine practice. There are basic things in establishing a telemedicine practice is A, configuration of the system, B, camera, C, connectivity. When I talk about telemedicine, I'm not talking of a WhatsApp video. I'm not talking of a telephonic consultation. I am talking of a professional telemedicine system. So real-time consultation. There are two types of telemedicine. The best one would be real-time, where you actually interact with the patient through a video conferencing. You also have another type of teleconsultation called store and forward, which is quite okay for super specialists, for example. For example, I don't necessarily have to physically examine a patient when a younger neurosurgeon or a non-specialist neurosurgeon refers to a case to me. So I would be interacting only with the primary physician or the primary specialist, and this can be called store and forward, where all the data of the patient, the MRI images, etc., is sent to me. At my convenience, I go through it, and then I give a report to the doctor, not necessarily interacting with the patient. However, if you're interacting with the patient, you need a good minimum configuration. I mentioned the screen resolution, preferably 1000 into 1200, a microphone, an Adobe Flash Player, and so on and so forth. Now, in addition to the configuration of the system, the camera is very important. You require a high density resolution camera, focus cam. Today, webcams are good enough. You don't necessarily need to invest in very expensive video conferencing camera systems, but I would strongly advise using an external camera, a webcam, and don't depend only on the inbuilt camera inside the laptop, because you will be able to pan, tilt, zoom, etc., focus, and so on with a very inexpensive external camera. Connectivity, don't bother too much about this complex slide. Basically, today, 90% of teleconsultations are done through internet, through a fiber broadband, 3G, 4G, and hopefully within a year or two, even 5G will be available. VSAT, very small aperture terminal satellites, are indicated in 2023 only in remote, isolated, mountainous, hilly areas where terrestrial internet connectivity is not available. All the other types of connectivity, I don't think you should bother about it too much. There are various methods of telemedicine: video, audio, text also, namely a chatbot, messaging, email, fax, etc. This also comes under the broad word telemedicine. Before I forget, personally, I don't like the word telemedicine. I think the correct word is telehealth. Medicine implies a one-to-one relationship between a patient and a doctor, where we are primarily talking of diagnosis and treatment. Health is a much broader concept, where the beneficiary, we are talking of public health. During the pandemic, there was a tremendous illustration of how telehealth was used rather than telemedicine. This includes education, teaching the doctor, teaching the beneficiary, and so on. Newer technologies, as I said, you need to be ready with it. Video conferencing is not just focusing a camera on you. If you want to produce a wow effect, if you want your patient to feel, wow, that was a fantastic response, I never even knew that the doctor was not in front of me, you need to adhere to some of these. Artificial natural light, you should not be less than 2,800 lumens. Backlighting helps the body stand out. The dress is very, very important. When you run an outpatient clinic, most of us are all of us are formally attired. Some of us wear a white coat and you wear a tie, etc. When you are at home, and a lot of teleconsultations are given from home, we tend to forget this. So formal dressing is important. The way the camera is placed, walls, the color of the dress you wear, the distance of your room from the ceiling, and so on and so forth. All this is very, very important. You can see where the speakers are placed. where the central processing unit is, the keyboard, mouse. But all this is only for a formal telemedicine room. It is really not required if you're giving teleconsultations from home. Let us accept it. Today in 2023 is all about digital marketing. Even the government of India spends billions of dollars, literally millions, if not billions, on marketing in the whole world is concerned. So we need to create an awareness. You need to create an awareness about your availability as a teleconsultant. You need to convince the beneficiary that you have been certified, for example, by the Telemedicine Society of India or other agencies. Today, there are certificate diploma courses which have just been started. Then, of course, acquisition, the landing page, the website, inquiry forms, and so on, social media, engaging with regular posts, create a custom audience, and so on. For a hospital, the primary target are patients and doctors, for hospital as well as patients. So all this you need to do. However, please understand that digital marketing, there are guidelines. At the end of the day, we are doctors. We should never ever breach what could be considered as unethical. Do not cross the Lakshman Rekha of ethical advertising. Do not use superlatives. Do not promote specific services. Do not reveal sensitive patient information. The National Medical Commission has recently said that even if you anonymize a patient, you shall not post any pictures, pre-operative, post-operative, etc. on Facebook or any other social media. Paid advertising is strictly taboo and action can be taken against you. So we need to follow the Indian Medical Council's professional conduct ethic and so on. I had mentioned earlier that we need not be worried about rules and regulations. Basically, the single word which I use again and again is trust. Absolute faith and trust. You need to trust your patient. The patient needs to trust you. The professional judgment of a registered medical practitioner, this alone is the guiding principle for any teleconsultation. You and you alone will decide whether a technology-based consultation is sufficient or a face-to-face consultation is required. The practitioner should exercise proper discretion and not compromise on the quality of care. Essentially, we are talking of the context. You need to identify yourself, and more important, you need to be sure that it is the patient whose investigations you have already seen, perhaps a CT, MRI, ultrasound, whatever it is. The consent should have been there, type of consultation, patient evaluation, patient management, and record all this. Telehealth has many, many applications. Diagnosis and treatment is only a small component. We have in our own personal department used CAMs for mass telescreening of diabetes, cancer, other NCDs where specialists are available on a screen. With paramedics, we have screened tens of thousands of people, had an HbA1c, had a random blood sugar done, and if it is abnormal, consulted with a doctor, a nutritionist, specialist, and so on using telemedicine. Tele-home healthcare. Today, houses can be converted into step-down ICUs, diagnostic services like teleradiology. We all know there's an acute shortage of radiologists in India also, and today there are at least 100 teleradiology units in the country, and thousands of images are reported every single day. Tele-CME programs, because of the pandemic, hundreds of webinars were held, and even today, the number of webinars probably still exceed the number of face-to-face CME programs. Teleproctoring, telementoring, telemonitoring, teleconferencing. The word tele can be added before almost all the things we do. It's a matter of great pride that the Indian Council of Medical Research, that the National Center for Disease Informatics and Research have brought out guidelines which are all available online. They have given very detailed guidelines on the framework for telemedicine use in the management of cancer, diabetes, cardiovascular disease, stroke, and so on. The Indian Psychiatric Society has gone one step further. They have provided a 50-page document in which every single step in telepsychiatry in the management of mental health remotely needs to be done. And because of the proactive measures taken by the All India Psychiatric Society, the telemedicine practice guidelines version 2.0 now includes drugs. A prescription can be given by a psychiatrist remotely as well. I'm quickly going to run through a few clinical examples just to tell you that I have not been talking theory all this time. This is all practically what we do. Today, the institution where I am associated with, we do almost 20,000 teleconsultations every single day. Of course, this has taken 2 decades for us to reach this level. You can see here, probably the world's largest tele-ophthalmology public-private partnership project, which we run in Andhra Pradesh, 115 tele-ophthalmology centers, almost 10 to 15 people come every day, and 30 ophthalmologists from Chennai remotely look at the fundus, and within 25 minutes, a computer-generated report like the one you see on the screen is given to the patient. We are doing several major public-private partnerships. We run the world's only 24/7 tele-emergency center. Several papers have been published, chapters have been written in textbooks. More than 2,000 people have received state-of-the-art treatment at a height of 14,500 feet in the Himalayas when the temperature is minus 25 degrees centigrade. This is one of my favorite slides. This was in 2002 when I had given a lecture at Port Blair, Andaman and Nicobar Islands. And following my talk, a few weeks later, a technician called me. Remember, this was in 2002. There was only one email facility available in the Chief Secretary's office. A very smart technician. He took a camera, took a photograph, sent it to me, and I was able to manage an unconscious patient in 2002 from the comfort of my home. Patient was discharged 2 weeks later. On the right-hand side, a few examples of how one can do detailed neurological examination. All this was done 20 years ago. The top photograph on the right shows a bead of pus. This patient happened to be in Tanzania. As I said, it doesn't matter which continent the patient is. All you need is a stable internet and a reasonably good video conferencing camera. I had to advise removal of the skull flap because the patient would develop osteomyelitis, brain abscess, and so on and so forth. A patient with multinodular goiter, dermatology, 99% success rate through a remote consultation, provided the dermatologist knows his job. Again, 2001, as early as 2001, I hope you can see this video on your screen. You can see how we have done tele-echocardiograms from the village of Araganda. Nowhere in the world has this been done. Unfortunately, we were all so busy that time, we just did not publish it. And my pediatric cardiologist is evaluating an echocardiogram done in a village 300 kilometers away from a tertiary corporate hospital in the city of Madras. So this is what is really happening. During the height of the pandemic, e-neuro intensive care unit, a ICU unit in Hyderabad was connected to 17 different states. And here, this was a paper which I published on 61 severe neurological cases in a general ICU who were managed remotely from a quaternary care hospital in Hyderabad. And this is the power of telemedicine, what it can do. As I mentioned earlier, I belong to the BC era. I refuse to give an opinion on a CT scan or an MRI or any investigation. I insist on seeing the patient. It is so simple. On the left-hand side, you can see an entry-level old mobile phone, not even a smartphone. I don't remember when I think this was taken about 7 or 8 years ago, maybe. And you can see I am in Madras. The patient is in a small town in Tamil Nadu, post-head injury sequelae. You can see how the family members have focused the camera on him. I can see he is on a Riles tube. I can see that he needs assistance to walk, etc. And this is all that I require. Examples of teledermatology. My dermatologist has done more than 12,000 teleconsultations and several papers have been published on this. Again, I'm going to show you a video. This is the power of telemedicine. It's at 2 o'clock in the morning. I'm at home. Nowhere in the world would a very senior neurosurgeon be present seeing the patient when the patient is admitted at 2 o'clock in the morning. The duty doctor with an ordinary phone, webcam, transfers the picture to me, and this is in my house, my laptop, no special equipment, nothing required. I'm able to evaluate the patient and tell the patient's relatives what is to be done and that no surgery is required. This is the power of telemedicine. Here again, you can see a small town. I'm examining the patient in his house. This patient has got a bilateral chronic subdural hematoma. Normally, a neurosurgeon would have advised surgery, but the patient is relatively asymptomatic. I did a detailed neurological examination. I was confident, based on my extensive experience, that I could manage the patient without surgery. And every week, though he was 250 miles away from me, every week I examined him, and exactly as predicted, a couple of weeks later, the subdural totally resolved. This picture speaks for itself, a classical example of a temporal lobe seizure. You can see this young boy staring with a vacant look on his face, looking around, and in a few seconds, you will see saliva drooling from the mouth. You can see how he's not aware of the environment. There, you can see saliva dripping from the mouth. Now, this is not a tonic-clonic grand mal seizure. Based only on the history, it may have been difficult to make a categoric diagnosis of it. Then you can see now the postictal is come back to normal. All that it took was a video for. I told the parents that though the history suggests seizures, I will not put him on anticonvulsants. I said nothing is going to happen. Next seizure, he gets take a photograph and send it to me. And now, with 200% confidence, I knew that this was a temporal lobe seizure. Yet another patient came to me in my consulting room. I said I refuse to give an opinion unless I see the patient. And here you can see the patient is using his own mobile and asking his friend, his brother and all that in his relative's house. This is all that I need. I don't require sophisticated video conferencing camera. Here I am seeing the mobile phone, and this tells me very clearly what is it that the patient can do and what is it that the patient cannot do. I'm going to spend a few minutes on this video. This is a video I made specially for teaching purposes. As you can see very carefully on this slide, permission has been obtained from so-and-so to record video of the teleconsultation and use it purely for teaching purposes. Now, this is how a prescription needs to be given. A prescription must be given on your letterhead. The patient needs to be sure that you are the doctor with whom he or she has fixed an appointment. And therefore, I have put my photograph on the top left-hand side, my qualifications, my designation, my registration number with the Tamil Nadu Medical Council. After examining the patient, now look very carefully how I have prepared the prescription for Mrs. So-and-so. I have anonymized it, 34 years female, diagnosis. Whenever you give an e-prescription, it is mandatory that the full diagnosis must be written. You can see here, right-sided trigeminal schwannoma, cyberknife irradiation done on October 2019. For the last 2 days, the patient has come to me for right hemifacial pain. It takes me only 45 seconds for a specialist to write down exactly what is the problem. Remote clinical evaluation. I have examined her, no focal neurological deficit. These are my findings. I've also mentioned that I have not examined the fundus, and I excuse myself, or I say I'm justified in making a diagnosis because she has no symptoms or signs of ICT, because I know the patient, I had treated the patient earlier. What is my treatment? carbamazepine. I have not prescribed Tegretol, Mesatol, Zeptol, and so on. I've only written the generic name. 100 milligrams, one at 8 a.m., 100 milligrams, one at 8 p.m. for 10 days. Telephonic review. I do not want a video consultation again because it's difficult, it's more expensive, and so on. Telephonic consultation after 10 days to call such and such a number. Then I put a JPEG image, which is strictly speaking not acceptable. Today, I have an e-mudra digital signature encrypted. I would strongly advise everyone to get one. It costs about 1,800 rupees. It's valid for 3 years. You can use it multiple number of times a day. The date on which the consultation was done. And here you can see the actual consultation. See, a detailed neurological examination can be done anywhere in the world. I am making use of the patient's daughter to find out if there is a diminution of touch sensation or not. The examination should obviously be relevant to the diagnosis. In this particular case, I have treated the patient, so I'm only examining the 5th nerve, 6th nerve, and 7th nerve in great detail. This is exactly what I would have done had the patient come to me physically. Now let's talk the future of telemedicine. I believe that telemedicine will no longer be like it was when I started, a standalone independent product. Telehealth will be a fully integrated component of what will be called digital health. I'm certainly excited that the National Digital Health Mission is trying to digitize every single aspect of healthcare. This augurs very well for the future. Telehealth services, as I mentioned earlier, there is a cost. Nothing in this world is free. Somebody has to pay for it, either the patient or the government or the insurance company, etc. One has to make it revenue generating, otherwise it will never be self-sustaining. Incentivizing all stakeholders. See, the mobile network operator is happy because every time I give a teleconsultation, I use bandwidth and he gets paid for it. The video conferencing camera seller is very happy because I buy the system, and so on. Similarly, the doctor who's giving the teleconsultation, he needs, in some way, there has to be an incentive, a carrot or a stick. Maybe it is part of his job description and he gets a salary at the end of the month from his employer. Fine. Or he may be in private practice where his time is valuable and therefore he needs to be reimbursed. The government is today has become, in the last one and a half years, a major player in deploying telehealth. E-Sanjeevani, which has been prepared by CDAC, which is now the recommended software for all government organizations and so on. I think they have reached almost 15 million teleconsultations in the last 1.5 years. And I think that telemedicine is here to stay. I would like to emphasize again and again that ultimately technology is only a means to achieve an end. Body language on a screen is very critical. We often forget that our patients, many of our patients may not have been to an engineering college or a medical college, may not even be graduates, but they certainly are far more intelligent than the director of All India Institute of Medical Science in evaluating the doctor. In 45 seconds, any patient can find out whether the teleconsultant is serious, whether he's empathizing with the patient, sympathizing with the patient. As the Mayo brothers said 150 years ago, patients don't care how much you know. They don't care how many papers you have published. They don't care the various fellowships you have. All they want to know is how much you care for them. There is a danger that by using telemedicine, teleconsultation, we may be depersonalizing healthcare. Nothing like having a touch, nothing like touching the patient, nothing like feeling his pulse, nothing that looking at him straight in the eye. But those who say that telemedicine will never ever be able to provide this, I beg to disagree. I have personally given about 6,000 teleconsultations in neurology, neurosurgery. Every one of the things which I mentioned earlier can be done remotely, so long as you listen to the patient. It was a William Osler who said again in the last century, he said, listen, listen, listen. The patient is telling you the diagnosis. Yes, EMR is important. Electronic health systems are important. MRI, mammograms, ultrasound, all these are important. But nothing is as important as listening to the patient, understanding with the patient, empathizing, sympathizing with the patient, getting into the mind of the patient, making the patient believe that for the next 5 minutes, 7 minutes, he is the only reason for your existence. Before I conclude, I would like to show that today telemedicine is not restricted to Earth. And again, it's a matter of great happiness and pride that ISRO, Indian Space Research Organization, have already embarked on major plans to manage the Gaganyaan mission, the Vyomonauts as they call them, the 3 Indian astronauts who are going to be 400 kilometers above the Earth for 7 days. Anything can happen at that time, and India is fully geared for it. And this is the ultimate in telemedicine, where we will not only be able to make a diagnosis when a human being is outside the Earth, but also will be able to treat it. Healthcare in the next few years, investment alone is going to be $217 billion. Make in India for the world, 12 million jobs in healthcare, National Digital Health Mission, digital payments, e-currency was just formally inaugurated a few days ago. Personalized medicine, participatory medicine. 850 districts, each will have a medical college. It's my dream that every medical college, every healthcare institution, whether it's a DNB accredited center or not, will eventually have a department of telemedicine. We already are on the way to becoming the most connected IT savvy society in the whole world. 5G, we will probably be the 5th or the 6th country in the world which will have 5G services within the next 1 year or so. So what is my take-home message? My take-home message is that the management plan ultimately has to be customized, factoring history, geography, socioeconomic status, natural history vis-a-vis, different interventions, and of course, your own competence. Evidence-based medicine, algorithms, flowcharts, protocols, standard operating procedure, big data analytics, access to Dr. Watson, the IBM computer, all this, yes, gives suggestions, but you and you alone should take the final call. EQ, not IQ, EQ, emotional quotient program in AI. Even an AI robot, which is programmed with EQ, can never, ever substitute the God-given limbic system. Your patient of the future, why future? Patient tomorrow is an e-patient, electronic, equipped, enabled, empowered, engaged, and whether you like it or not, Dr. Google and Mr. Facebook have ensured that your patient at least has access to all the information you have. Gone are the days when you could consider yourself as the only expert. Today, the patient will know almost as much, and in some cases more, than what you know. Facilitated by wearables, health sensors, and other innovations, making patients the proof of contact. So, ladies and gentlemen, finally, the ideal healthcare provider in the next few years. Why next few years? Why not tomorrow? Why not today? The ideal healthcare provider is one who has the surgical skills of Sushruta, the compassion of Mother Teresa, the pragmatism of Lord Krishna as enunciated in the Bhagavad Gita, the genius of Albert Einstein, the innovativeness of Steve Jobs, who invented the iPhone. All this together makes you a superman. Thou shalt digitally transform. It is not the strongest of the species that survives, not the most intelligent. This is not my statement. This is what Charles Darwin said, but the one that is most responsive to change. If you do not embrace telehealth and make it an integral part of the healthcare delivery system of which you are a member, you will soon go into oblivion and you will start belonging to the Jurassic Park. Whether you like it or not, telehealth is here to stay. When I started telemedicine in 1998, everybody laughed and ridiculed. Today, thanks to the coronavirus, the entire world has accepted that there is a major role for remote healthcare, technology-enabled remote healthcare to play. Not in the lifetime of my great-grandchildren will there be enough doctors, enough specialists, super specialists, enough brick-and-mortar hospitals, but at that time, our digital literacy and our ICT availability will be almost 90 to 95%. The rural tele-density of India has already reached a staggering 80%. And I think in the next 10 years, I will not be surprised if 95% of India's population are equipped with a phone. If our grandchildren may not be our children, our grandchildren will never ever forgive us if we do not exploit and capitalize on this technology to make healthcare available to anyone, anytime, anywhere. Health is a fundamental right, and we owe it to the next generation. I would once again like to thank the Maharashtra Medical Council for taking this much needed initiative. I would be happy to get a feedback and once again place on record my gratitude to the Maharashtra Medical Council. Thank you.